Good evening, everybody. Thank you for sticking around for this last session. Now we're doing as a plenary session in this first annual Congress of the Arab Thyroid Association. Hopefully you had a fruitful meeting throughout the sessions today. So it's my dear honor and a pleasure to present our last speaker for tonight, or for our session, which is a plenary session, Dr. Tarik Alhadd. Dr. Tarik is a graduate of Faculty of Medicine at Khartoum University. He holds the degree of MRCP in UK from 1992. He completed training in diabetes endocrinology at the Department of Endocrinology at the North Staffordshire Hospital in UK. He has several positions, including Professor of Medicine at the University of Medical Sciences and Technology in Khartoum, and also including at Hamad Medical Corporation in Qatar since 2014. He serves also as Associate Editor of the Sudan Medical Journal, and he's also currently the Secretary General of the Gulf Association of Endocrinology and Diabetes. He's also a member of the Arab Thyroid Association. He has authored and co-authored many publications and chapter books and been appearing in many regional conferences. It's a great pleasure to introduce him to give his presentation, which is COVID-19 infection and the thyroid. You can start your presentation, Dr. Tarik.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Tarik Alhadd. It takes me great pleasure actually to give you a presentation on COVID-19 and thyroid dysfunction in the auspices of the first conference of the Arab Thyroid Association. As we know, the coronavirus pandemic started from the first cases that appeared in Wuhan in China in December 2019, and following that there was an explosion actually of cases with the formation of the pandemic, and this actually continued till our present day. The WHO guidelines does not actually recommend screening for thyroid dysfunction. However, the accumulating evidence actually of the rampant involvement of thyroid with the COVID virus does negate against this. We know that the coronavirus is an RNA virus, and it does exhibit a marked respiratory tropism, causing mainly sort of a respiratory infection that might progress to pneumonitis and ARDS, and it could be actually quite devastating, resulting in multi-organ failure and ultimate death. And the virus does actually anchor itself through the ACE2 receptor as well as other transmembrane proteins, and this will trigger actually a cascade of virus replications that result in a process of programmed cell death called pyroptosis. And this result also in the release of very harmful intracellular molecules. The mechanisms of cell injury and tissue damage triggered by the virus tend to be quite actually diverse, and it does actually involve, as we know, release of the pro-inflammatory cytokines, and this will release various substances from the cells that actually cause destruction as well as activation of the immune responses. And the activation of the immune responses does involve primarily the cytokines, IL-beta, as well as tumor necrosis factor and interleukin, interferon, gamma, and others. And this will result actually in the immune response hyperactivity with uncontrolled systemic inflammatory response. And we know that also from research that the T helper 1 and T helper 17 immune responses tend to be actually quite hyperactivated in these patients. So the spectrum of the clinical presentation of COVID, as we know, could be either atypical or could be classical with mild respiratory disease or a devastating severe multisystem disease, or it could well be an asymptomatic, which is responsible actually for the wide spread of the virus. Likewise, the clinical presentations of COVID might also be actually with other non-typical presentations that include other systemic involvement like renal failure, like liver disease, rhabdomyolysis, as well as endocrine dysfunction. And when we move into our actually topic of COVID-19 and the thyroid, we know that the ACE2 and the other transmembrane proteases are very highly expressed actually in the thyroid, more than we see in the lungs. And this expression tend to be both positively as well as negatively expressed in relation to various immune signatures. And the uptake by the host cells of the SARS-CoV-2 is thought to be mediated by other actually cellular proteases. One main group of the cellular membrane proteins involved in the thyroid is thought to be the integrins, and we know that the ACE2 does bind to the integrins, and this modulate actually downstream signal sort of pathways. And we know that the free thyroid hormone does regulate actual expression of genes that control the monomeric protein that make up the integrins. And thyroid hormones also are deemed to be very crucial to promote the internalization of the integrins into the cells. As a matter of interest, the olfactory receptors are co-expressed with the ACE2 and other cell proteases, and the olfactory receptors are widely actually expressed in the thyroid, and the impairment of these ORs is responsible for the anosmia observed in many COVID victims, and damage to the these olfactory receptors due to COVID is postulated to be contributing to the impairment of other organs expressing OR, not excluding the thyroid. So the thyroid may be directly or indirectly damaged through the activity and the hyperactivity of the T helper 1 and the T helper 17, as well as the cytokine storm that may trigger and perpetuate the thyroid gland inflammation, and the impairment of the hypothalamic pituitary thyroid axis as a direct actually effect from the virus, thought to be playing a very important role. And the immune histochemistry from the actually cadaveric sort of histopathology showed that the adeno hypothesis has shown actually both reduced number of the cells as well as immune reactivity, and this also being described in the thyrotroph cells. So the SARS-CoV-2 virus might involve the thyroid either through the central controlling pathways or directly through the effect on the follicular cells. And this may take actually the shape of quite diverse and protein clinical syndromes ranging from thyrotoxicosis, hypothyroidism, as well as non-thyroidal illness. And when we talk about non-thyroidal illness, this tend to be the most common abnormality actually observed in COVID patients, and it has been well described actually in patients in ICU as well as patients who are hospitalized. And we know that the non-thyroidal illness is a syndrome of low TSH with low normal T4 and low T3. And it does actually occur at all spectrum of the illness. And the involvement of a plethora of cytokines is thought to be actually behind its pathophysiology. So it is actually been well researched, and it has been suggested that the T3 was observed in several studies to be a marker for more adverse outcomes. However, long-term and longitudinal follow-up of COVID patients who has been subjected to non-steroidal illness is highly warranted in order to unravel the natural history of this condition in patients with a previous history of COVID infection. As we know, the thyrotoxicosis might be related to subacute thyroiditis, might be caused by painless thyroiditis, or might be caused by Graves' disease, and hypothyroidism could be either primary or it could be central. The destructive thyroiditis could well be subclinical as well as it could be clinical, and it might take the form of either subacute thyroiditis or painless thyroiditis. The subacute disease has been actually suggested to occur in 15 to 20% of COVID-19 patients. Neither autoimmune or non-immune thyroid disease are risk factors for subacute thyroiditis. And we should remember that neck pain is the hallmark of the disease in subacute thyroiditis. The classical course, as we all know, is that there is an initial phase of hyperthyroidism followed by hypothyroidism, then euthyroidism, which tend to run a course maybe up to a period of 6 months, and it may occur either simultaneously with the COVID-19 or following its resolution. And transient thyrotoxicosis could well be severe, and it might warrant actually treatment with symptomatic agents like beta blockers, and all types of thyroiditis may progress to permanent hypothyroidism, akin to what happened generally in this very common actually clinical syndrome. On the other hand, atypical thyroiditis can occur in up to around 15% of forms of subacute thyroiditis without neck pain, and this has been actually shown to be associated of lymphopenia. Here I mean the absence of neck pain, and it was first recognized in COVID-19 patients admitted to ICU, and we know that the hallmark is low TSH, low T3, as well as high T4, and this was the reason behind coining the name of thyroxine thyrotoxicosis, and it does occur actually in more commonly in males, and the explanation for the gender difference is that the immune signatures associated with ACE2 as the thyroid cells is responsible for such differential effect of gender. Hypothyroidism, on the other hand, is quite rare, and it's extremely rare actually also in our experience. It does happen only around 5% of cases. Despite that, subclinical hypothyroidism might be seen quite common, and it might actually occur during or after the course of the COVID-19 infection, and it is associated generally with the Graves' prognosis. Central hypothyroidism is far less common, and it might actually be only transient, and this might actually be the manifestation of the transient effect on the hypothalamic pituitary thyroid axis. On the other hand, Graves' disease is well established to be related to the triggering of the autoimmune diseases, which has been well recognized in the aftermath of SARS-CoV-19 infection. And we know that a diversity of autoimmune conditions like antiphospholipid syndrome, autoimmune thrombocytopenia, hemolytic anemia, Guillain-Barré, and name it. And this may persist long after the resolution of COVID-19 infection, and the evidence for COVID to amplify or promote autoimmune disorders is very strong. This is rather not updated sort of information, but up to the interesting review by Dr. Morgan and Dr. Zahrani in June 2021, published in Endocrine, around 5 cases of Graves' disease were reported, and then more, actually 5 cases were reported from our center. I will come to that. And classically, there is a sort of a female preponderance, and the age range tend to be typical for those normally afflicted by the condition itself. Cases of Graves' disease tend to have the classical and distinct, actually, clinical, radiological, as well as biochemical abnormalities. Most of them will have positive TSH receptor antibodies, and the radioisotope scan does actually show increased uptake, and all of them generally do have quite good response to the antithyroid treatment. The excellent review by Morgan and Al-Zahrani suggested what sort of postulated mechanisms, and this is resting upon the elucidation of the phenotypic expression of thyroid autoimmunity, which has been thought to be loss of balance between T helper 1 and T helper 2, where the predominant upper hand T1 helper mediated immune responses does predominate, and this will trigger actually the apoptotic pathway in the thyroid follicular cells that result actually in the expression of the clinical disease. And stress has been shown to shift the balance towards T helper 2 that favors development of Graves' disease. The regulatory CD4 and T cells, what is known as TREGs, do inhibit actually the effector T cells, and this could well actually differentiate into T helper 1, T helper 2, or T helper 17, and this is dependent on the cytokine milieu, which is actually rampant during that time. And the activity of these cell lines has been shown in animal models to augment cytokine production. All these do suggest a viral-induced Graves' disease, which is likely to be mediated by the T helper 17 cell series. I would like just to point to a very interesting review that actually been published a few months ago, and this have actually complement our clinical observation as well as the various case reports that vaccination against the COVID-19 virus might also trigger thyroid dysfunction. And this excellent paper was published in Journal of Endocrinological Investigation of the Italian Endocrine Society. And it does suggest that actually vaccination primarily is 68% of cases of mRNA-based vaccine may trigger actually thyroid dysfunction, and around 15% of viral vector vaccine-based as well as inactivated vaccines. The clinical presentations is generally subacute thyroiditis in around 60%, but in around 25% cases of Graves' hyperthyroidism has been actually observed. And 58% of subacute thyroiditis and 62% of Graves' disease, the condition might follow the first dose of the vaccine with a mean to median of 10 days following vaccination. And in around 40% of subacute thyroiditis and 38% of Graves' disease, the condition followed second dose with a median lapse of around 14 days after vaccination. However, the good news is that the outcome is favorable in most cases, in contrast to the thyroid dysfunction caused by the original virus. Interestingly enough, one case of thyroid eye disease reactivation has been thought to be associated with COVID-19, and this is actually reported from Taiwan, published in Taiwan Journal of Ophthalmology earlier this year. A diverse presentation of thyroid dysfunction, including postpartum thyroiditis, has been reported. This is a case report in the Endocrine Journal back by the end of 2021 of one case actually from Japan. And just quickly, before I wrap up, just to tell you about our center experience, which has been recently accepted for publication. We have collected around 10 cases in a sort of a period of 1 year from October 2020 to 2021. And it is primarily from outpatient facilities, mainly around 5 cases of Graves' disease, as well as, isolated cases of chronic primary hypothyroidism and central hypothyroidism, as well as subacute thyroiditis. So, in summary, the evidence for SARS-CoV-2 virus in causing thyroid dysfunction is accumulating. This is very clinically meaningful to the extent that it warrants more vigilance among the clinicians, and screening, therefore, may be warranted in these patients, in contrast to what has not been suggested by the WHO. More clinical and basic science research is expected to come to the fore in the near future. Thank you very much. And at the end, I would like to just acknowledge the invaluable contribution and support of my colleagues, Dr. Zainab Dabbous, Dr. Mohammed Bashir, Dr. Stephen Beer, and Dr. Wajiha Gul, as well as the very helpful expert opinion from Dr. Ali Saeed al-Zahrani from Saudi Arabia. Thank you very much.
Thank you, Dr. Tarik, for this wonderful presentation. We appreciate your efforts and your presence with us. Since this is a plenary session, we will not have questions and answers. So we're very thankful for your joining us and presenting this talk. So I think this concludes the sessions for all the first day of the first annual Congress of the Arab Thyroid Association. I hope you had a great time joining in these presentations and parallel sessions. Hopefully you join us tomorrow on our second day in the Congress. Tomorrow will start at 1 p.m. Riyadh time. Hopefully you'll have wonderful time tomorrow also. We'll have plenty of activities, including state-of-the-art lectures, abstract presentation, and also thyroid grand rounds. Looking forward for your attendance. Thank you so much. Have a pleasant evening.